Good afternoon, everybody, and welcome to the webinar. I am Andrea Baer, the Executive Director here at Mended Hearts, and I am so excited to be with you all today. Today's topic is in our Stay in Care series, and the topic is being a proactive patient to get the heart care you need during a pandemic. And this will be lessons from the TAVR Frontlines. Just a few housekeeping rules before we get started. All attendees are in listen-only mode. If you can't hear, hopefully you can see the slides. Check the audio button on your personal computer itself to make sure that the sound is on. That's usually the issue. During the presentation, type your questions into the Q&A box because the moderator will be answering your questions at the end. We'll ask the panelists the questions for you, but you can type those questions in the chat box anytime. The PDF version of the slides, as well as the presentation, will be available on the Mended Hearts website following the event. So Mended Hearts, if you don't know a lot about us, we are a national community-based nonprofit organization whose mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. I am Andrea Baer, as I said earlier, the Executive Director here at Mended Hearts, and I also have with me Jody Smith, the National Program Director for the Mended Hearts, and we will be the moderators for today. With us, we are so happy to have Patricia Keegan, the Director of Strategic Program Initiatives and lead APP Structural Heart and Valve Center at Emory Healthcare. And also we have Kathy Holler, who is a heart valve patient and TAVR recipient from Emory University Hospital in Atlanta, Georgia. And we all know how Zoom is, and sometimes bandwidth doesn't agree with us. Kathy is not showing her screen, but I promise you she's here, and she looks beautiful in her picture. And but you won't be able to see her face today. On today's agenda, we have balancing COVID concerns with the risk of delaying heart treatment, being proactive and staying in care, and being proactive and staying in care in a pandemic environment. Then we're going to talk a little about TAVR during COVID, the patient experience, and then we'll go to question and answers. And as I said, please feel free to type your questions in the chat box at any time during the presentation, and we will moderate those questions out at the end. We have plenty of time for Q&A. But without further ado, I would love to introduce you and turn the floor over to Patricia Keegan. Thank you for joining us today.
Thank you so much. And just a huge thank you to Andrea Baer and Jody Smith and the entire Mended Hearts and Little Mended Hearts family for inviting me to participate in today's program. And obviously, I also need to give a special thank you to my Emory Healthcare colleagues and to our healthcare heroes everywhere around the United States who have been really working so hard to provide care for our patients. And so our talk today is really just kind of talking about heart valve replacement. And, typically under normal circumstances, aortic stenosis is critical. And when we look at the statistics, people who've developed symptoms from severe aortic stenosis have about a 50% chance of living 2 years and 20% of 5 years without having an aortic valve replacement. And so the thing about aortic stenosis is it's progressive. The only cure for aortic is to replace the valve itself. And this can be done either through open heart surgery or catheter-based procedures like TAVR. And why are we even talking about this topic? And I really just want to applaud Mended Hearts for tackling this important topic. It's a confusing, scary time for patients, and I just really want to acknowledge that. And there are many important considerations for heart valve patients. And even under normal circumstances, or we'll say pre-COVID, we know there's a poor prognosis if we wait to treat this heart valve disease, and survival is worse than many metastatic cancers. We know this disease doesn't wait well, and so symptoms are hard to detect and track. At the rate of progression is unpredictable. And so we don't know if somebody is going to have symptoms or have problems in 1 month, 1 year, or 10 years. And right now, what we see is people aren't doing their normal activities. And so really kind of classifying what those symptoms are can be rather difficult. And many patients assume, even pre-COVID, is that a lot of the symptoms are just signs of aging when they're really not. They're a sign of their heart valve disease. And so the bottom line is timely diagnosis, referral, and treatment are essential. And with the pandemic weighing, the risk and benefit of waiting becomes even more critical. And while I'm sharing these stats specific to heart valve disease, these general messages apply to all patients with various forms of heart disease in terms of the critical nature of being proactive, advocating for themselves and for their loved ones. And now I know I'll just take a minute to really just share my personal Emory experience at Emory University here in Georgia. What we know about COVID has changed a lot from early 2020 to the current time, and what we know is vastly different. It was a lot of learning on the job about how to manage this virus. Even for patients, it is important to evaluate the situation and look up reliable information that is the most up to date. And initially, when we first started learning about COVID, many programs just arbitrarily shut down because we didn't know what to do. And a lot of that was due to lack of information, and we needed to develop a plan of care to take care of patients safely and efficiently. And one of the ways that we were able to open back up and kind of proceed forward is just having constant communication among teams and our patients. As we look at this, here in Atlanta, we're really coming down from a third wave. And so a lot of what we've learned from our first two occurrences have really helped us to continue on. With that being said, we're still on our highest level of restriction for visitation. And even for our employees, we're required to wear, of course, masks everywhere and eye protection when we are seeing patients. So this became such a serious, state of affairs that a number of societies, and when I say societies, I mean organizations. So the American Heart Association, the American College of Cardiology, the Canadian Cardiovascular Society, put out a position paper on treating patients with structural heart valve disease. And when they put out these recommendations, the purpose of them is to guide practice across the healthcare system. And to help really continue with continuity of care. So the care that you would receive in Atlanta is the care that you would receive in Boise, is the care that you would receive in LA, is the care that you would receive in Miami, and so on and so forth. The established priorities of care involve minimizing exposure to coronavirus. So we certainly don't want to expose our patients nor each other. Maintain high quality and durable structural heart outcomes for those who require procedures. So your procedure shouldn't be any more risky than it would on a normal day, and have that same safety and efficacy. We had to look at what our resource utilization is. There was a lot in the news about ventilators and hospital beds, and really thinking about those placements. But most importantly, what I think is preventing delay of intervention to those at high risk for clinical deterioration. So with everything going on, it leads a person to really think, why should I seek care? And so there have been a few studies that have shed some really interesting perspective during this time of pandemic. What has been highlighted is that we've seen an increase of deaths related to ischemic, which is coronary artery disease, and hypertensive heart disease in certain areas of the United States. Nationally, we've also seen a decrease in cardiac case volumes, and this includes coronary artery bypass and also valvular heart disease. And the patients who are coming in for treatment are actually sicker, which means higher acuity, or they're more critical, and definitely having increased deaths. And a lot of this is just looking at patients who have just kind of delayed care because they're afraid, or they're worried, or they don't want to take resources, and different people have different reasons for why that is. Specifically for TAVR, it's really, really interesting because there was a single center in New York City that put out their information. And what they had is 77 patients who were pending going for their TAVRs. 10% experienced a cardiac event in that first month. So we're talking about March to April, but then 35% experienced a cardiac event over the course of the next 3 months. And what they classified as a cardiac event was need for an urgent TAVR or even death. And so certainly, I think this highlights the importance of seeking care, especially for aortic stenosis. In March, many of our centers had shut down our programs. And so in May 2020, the American Heart Association published some guidance around timeframes to get patients in care. And this really helped organizations to triage patients and help guide the questions, how long can I wait? And who needs to go first? It has also helped to highlight about elective procedures and for patients being told a procedure is elective. And I just want to be sure to make sure that I state elective doesn't necessarily equate to optional. And so with heart valve disease, we know that it has to be done. It's just trying to predict if there's a little bit of time. And so what they came out and just classified, these were the patients that had to be done right away. And these were the patients had to be done as soon as possible. And here's the patients that we could safely do within 4 to 12 weeks. And so that gave us, really helped clarify the triaging of patients. And it really helped us show that it is vitally important to keep contact with patients. And at our particular center, we did have weekly check-ins with our patients. And again, this helped to actually provide some comfort to our patients to show there were guidelines and data behind what we were stating as well. So again, from our Emory experience, one thing that has been in the news that I just also want to acknowledge is we did have to shift some of our service lines. In our teams, not only did we need to consider procedures, but how we provided care to new patients and existing patients. Some of our staff was redeployed to hard-hit areas of the hospital, but we also recognize that our heart patients cannot and should not wait. We established care teams and pathways to better serve our patients by, moving our reliance on telemedicine. It wasn't something that we had really embraced, and certainly now it is something that we have embraced. And we've limited our exposure in our waiting rooms, medical offices, and hospitals. And so as we've shifted to telemedicine, we've noticed some pros and cons. And so it's been really great to be able to screen patients from the safety of their own home, with their family close by, and in a place that they feel comfortable. We provide low-risk urgent care for non-COVID conditions. We're able to treat chronic conditions and medication management without exposing the patient to the hospital or office, and assist patients who may have difficulty accessing care, and really emphasis on education. Of course, some of the difficulty is we just can't see a patient. We can't do that physical full exam. And sometimes it's just really better to be in person and lay eyes on somebody and have that personal connection. And the other thing, to be quite honest, is we're all on a computer today, but many of our patients just don't have access to either computer, camera, phone, or even internet. As we continue to adjust from the pandemic, there's new challenges that have to be addressed. Our center practices patient family-centered care, and this has really been difficult for all of us to adjust to no family or visitors. It was part of our culture. However, the visitor policies have been put in place to protect patients, staff, and families as we continue to battle COVID. We all look forward to going back to normal, or whatever that looks like for the future, but it's hard to know when or where this happens. Right now, our focus is on delivering safe and efficient patient care. And nationally, it can be really, really hard to know what information is the most reliable or current. Do not hesitate to reach out to your healthcare providers to discuss what is the current up-to-date protocols aimed at keeping our patients well. So what do we know from all of this that is working well? And, when I was kind of preparing for this, one of the sayings that came to mind was, don't let a good crisis go to waste. And depending on what resource you can find, it's either Rahm Emanuel or Winston Churchill. And I think the most reliable one I found was Machiavelli who said it. And so what do we know is working well? And that is the 3 W's, which have been put out by the CDC, which is wear your mask. And I'll put a little caveat to that, wear your mask correctly, wash your hands, and watch your distance. Safety protocols have been put in use for inside and outside healthcare settings. And with the advances in technology, certainly this is increasing convenience for our patient. And so I think that that has been a very positive in what's working well. And I think the other piece that's really been working well is an improvement in streamlined processes. For us, we've been able to go to a same-day discharge model for a lot of our TAVR, left atrial appendage occlusion, and even angioplasty patients, and expedite evaluation so that we're taking care of patients more efficiently and safely. So when we talk about how to take care of patients and what is that practical information, you know, for us, we want you to know that we are doing everything we possibly can to protect you and each other. We have employee screening, visitor screening, we have limitations on visitation, and limiting waiting room traffic to limit the patient to patient interaction. And so before you go, to your provider or to the hospital, you may want to know that visitor policy. Again, it's so important to follow the 3 W's. Make sure you track any symptoms, keeping in mind that maybe you're not doing your normal activities. You're not getting out and about as much as you used to. So maybe you don't have that shortness of breath, but do keep track of things like your weight and your salt intake. And then just a quick note, really consider vaccination. It's hard on a program like this to advise everybody what you should do, but, talk to your providers about getting the vaccination when it's your turn. So what are some things that we've learned? Communication with your heart team is essential, that safe, effective healthcare is possible during this crisis, and that unprecedented times call for creative solutions. We continue to learn every day. We all need to be flexible, adapt, work closely with our medical teams. So lastly, again, keeping patients safe go hand in hand with keeping the healthcare workers safe. It's a two-way street for both our patients and those of us that work in the hospitals and clinics. If we can reduce the number of physical contact encounters, it can be helpful only in appropriate cases. Use of video visits can be used wisely, but sometimes having that personal care is necessary for treatment. And if there's a concern about your physical symptoms or a change, it may be more appropriate for you to be seen by the provider in person. For visitor limitations, I greatly appreciate that this is the least popular measure. And honestly, it's the one I get called on the most. Nobody wants to head into a procedure alone. And this type of measure really does protect you and limits the number of community members within our hallways, cafeterias, and waiting areas. And this can help decrease the spread of infection among patients and employees. Of course, there are exceptions to these policies in cases where patients may have physical or cognitive disabilities or require caregiver or family support. Check with your hospital about what those exceptions may be. For masks, masks are a proven way to reduce transmission, especially when worn correctly by all parties and especially indoors. All patients and staff at our institution are required to wear masks when entering the hospital and when moving through hallways, stairs, elevators, etc. You may remove your mask once you are comfortably situated in your private room. However, we do ask for patients to put on your mask when the nursing or care teams are present. For screening, at the very least, you will, or actually I'll say you will be likely required to have a COVID-19 test before a scheduled procedure, and in some institutions before prior testing. In many institutions like mine, we do require an actual swab test within a certain time window, and for us that's 72 hours before your scheduled procedure. We don't typically do rapid testing as the resource is limited, and we do try to save those for higher risk emergency situations. With privacy and social distancing, it's unlikely that you will be in a hospital room that's shared. And so we try to do everything to ensure your privacy and social distancing from other patients. We do have units that COVID-19 patients are in designated areas and unlikely to be an area where you would be recovering from your TAVR. Adequate and appropriate PPE or masks, eye protection is essential for reducing transmission between patients and healthcare providers. If the rate of transmission between these two groups is low, then we know that the PPE is adequate. So after going through all this, I am so honored to be able to introduce Kathy Holer.
Thank you, Tricia. I will say to everyone that I am honored to be here today and to share my TAVR journey with everyone listening. I feel blessed to be here, and yet I'm very excited to share this journey with you. I'm a retired RN who, yes, I had some medical experience, but I was not a cardiac nurse. So some of this information was very new to me, and I felt like I needed to absorb everything I could so I could be my own best advocate. I'm a breast cancer survivor of 37 years. And with the TAVR procedure, I feel like I have just added more years to my life so I can enjoy what God intends me to have for the rest of my life. A little bit about my journey. I was being monitored by my primary physician and my cardiologist for many years, which we think some of my symptoms may have come from my treatment for breast cancer, mainly radiation and chemotherapy. My symptoms were increasingly becoming debilitating. And in addition to these symptoms from the aortic valve stenosis, I was also very hypertensive and I developed congestive heart failure. The shortness of breath, gasping for air upon even trying to climb the stairs or a hill, any kind of exertion. I was dizzy, fatigued, and as well as results from my testing, my EKGs, echoes, so forth, deemed me an urgent case. Well, that kind of flew me into another realm. I was not prepared for that. I knew that this day was coming, but I didn't know that it would be this soon. I was referred to Emory and qualified for the TAVR procedure. I had already done some research on this and talked with my cardiologist about it, and knew that that was the route I wanted to go versus open. But that was left up to my surgeon and the medical care team at Emory. There was a lot of testing, oh my, yes, lots of questions, exams, but I was so thankful for that medical technology that gave them the insight as to what's going on inside of me and what do I really need to have done. I met with a TAVR medical team and I was impressed with this. Not only did I meet with the surgeon, but there was a care manager, there were nursing staff, and I also had a direct line to a nurse to call at any time for any questions or concerns. Was I nervous? Oh my gosh, yes. Anxious? Most definitely. And scared? Absolutely. I was terrified at one point, and because this is my heart. Going through breast cancer and the ramifications of that was enough to put me into another realm. But I conquered that, and I conquered my fear of that. But this was my heart, and it was very instant. Everything that was happening was very instant, and that terrified me. So to aid in my decision of what to do, I realized that my aortic valve stenosis was certainly going to be terminal. I had to do something. And COVID was not always terminal. And there was definitely something that I could do about my heart. I was more concerned about my heart than I was about getting COVID. Everybody has their own opinion. This was mine. I thought this is something that I can do for myself, and COVID was not going to stand in my way. I knew what precautions to take myself. And after I met with a medical team at Emory, which we had numerous discussions on COVID, I felt more at ease, but I thought I have to be there to see this in action first. So I entered a little cautiously. Now they absolutely have no visitors in the clinic or hospital. However, at the time, excuse me, that I had my procedure, which was 3 months ago, my husband was able to be in the clinic with me. But in subsequent visits, he was not. So as Tricia alluded to earlier, the rules and the plans change according to what's going on with COVID. Also, as Tricia mentioned, I was tested for COVID prior to surgery. And in the hospital and clinics, there were hand sanitizer stations everywhere. Temperatures were performed at every department that you entered. Masks were definitely required. And social distancing was a must. Even the chairs were roped off, so you couldn't sit next to somebody if you wanted to. In preparation for the day of surgery, 3 months ago, my spouse was allowed to be with me in the holding area before I went to surgery. And I had to spend the night due to the timing of my surgery. It was late in the day. But also had been discussed was the possibility that if I had had my surgery early in the morning, I might have been able to go home the same day, which I thought was ludicrous. But now I see that that's totally possible. All staff entering my room, I was very impressed. They had appropriate PPE. They were friendly, talkative. They reached out with a gloved hand to just give me a pat, let me know I'm okay. They're there for me. They have empathy for you, I think, because they know you are alone and you have no one to reach out to except them. And I appreciate them being there for me in that post-op phase. I encourage patients to find your individual voice. Don't be afraid to ask those questions. Don't think there are any dumb or stupid questions, please. Say that you're scared of nerves or being alone or of hospitals or having surgery, whatever is your concern. Ask staff to explain each step of the surgical preparation. I remember going to the surgical suite and there were so many machines in there. And so I've never seen more staff in my life. But they told me what they were doing. I asked questions. I told them I was uncomfortable at one point. So don't be afraid to speak up and communicate with the staff that's there. I was very unfamiliar with this hospital, had never been there before. I'd never been alone before receiving any kind of care. But I kept thinking of the outcome and what it would mean to increase my survival. So in closing, I want to say that communication with your cardiologist, your surgeon, and your TAVR medical team or any other type of medical care team you have is absolutely key. You can make a list of questions and concerns, keep a log, if you will, maybe on a calendar for ease of communication of your symptoms, and be very descriptive so the physician and the care team know exactly if you have declined in some areas. The more information that you possess, your choices are a lot easier. And remember that everyone is unique. No two patients will have the same experience. So my experience was very positive. Some patients will not experience that. Look to your medical team for answers and to help you discuss those concerns that you have. And I will let you know on a side note that because my cardiologist deemed that I was high risk, I did talk with him about the COVID vaccine just a few weeks ago. And he said, definitely you need to get it. And tomorrow I have an appointment. So I am ready to face my life. So thank you for being here today. And I wish Godspeed to each and every one of you. Thank you.
Thank you so much, Kathy. That's great. And it's so nice to hear from someone who has actually been through the experience, especially over this past year. Hopefully it makes everyone feel a little better. We are going to move into the question and answer period. And I can tell you now we have tons of questions. So I am going to jump right in. Patricia, I'm going to start with you because the first two questions are about the big elephant in the room, and I'm sure everybody's thinking about it. COVID vaccines post TAVR. Is it safe? Should we get it? What's the medical community saying?
The medical community is saying they absolutely recommend getting the COVID vaccination for, quite honestly, any heart patient, even transplants. So in these cases, we do recommend that our patients get the COVID vaccine post TAVR.
And is there a preference, or is there which one is better, or does it matter? Should we just go for whatever we can get?
Exactly. There is no preference, and right now our organization does offer both the Pfizer and the Moderna vaccine. And I anticipate if Johnson & Johnson gets approved, we'll offer that one as well. And they do work a little bit differently. But again, if you have any questions or concerns, don't hesitate to have a conversation with your provider. But the CDC has really put out some excellent guidance on COVID vaccination, and it is recommended in cardiac patients.
Great, thank you. Kathy, this question is for you. We have someone asking what your comfort or discomfort level after the procedure was and what your main problem afterwards was.
Well, let me address the main problem after the procedure was lying flat on my back. And it's, plus you have weights on each groin site, which really didn't bother me at all. But it was the lying on my back and getting some muscle cramps and that type of thing. Plus I did have some nausea and vomiting from the, we believe it's from the anesthesia that I had, which was not general anesthesia. I will make that clear. It was a combination of drugs that they give you to relax you, and you're kind of in a twilight sleep stage. And I didn't feel scared post procedure at all. It was just I guess the feeling of being uncomfortable at that time and not being able to move like I wanted to. But the staff were very nice, and at one point, once the weights had been removed, I was able to roll on my side as long as I stayed in alignment, and that did provide a lot of relief. So again, I emphasize to talk with your staff, your nurse, whoever is in your room, or ring for assistance and let them know that you're just not comfortable.
Great. It's so nice to hear there wasn't a whole ton of pain or discomfort post.
Oh, no, not with this procedure at all. I had no chest pain, no discomfort. And even at the groin sites, there was no discomfort. I do remember getting up for the first time, and it was a kind of a feeling of heaviness in a way, but after walking and being up, that dissipated. So that was not a big issue. So again, it was just that uncomfortable being flat on your back and getting some muscle aches and things like that.
Great, thank you. Patricia, this question is for you. The attendee wants to know, how significant is an echo in learning about valve disease? And does the surgeon need to see the CD pictures or just the write-up of a echo?
Quite honestly, so one interesting thing, just to kind of take it back, is by design, patients may see a surgeon or they may see an interventional cardiologist who's familiar with TAVR, but the biggest thing is that they're actually evaluated by a team. And when we say patients are evaluated, they are, all options are discussed for all treatments. So when we talk about TAVR, an echo is kind of an answer. It gives us some necessary information. I will tell you, the pictures, as they say, are worth 1,000 words, because some of the echo is done, and it is really up to personal interpretation. And so seeing those pictures really helps give us information. Quite honestly, if if I don't have pictures, it becomes very difficult to be able to make a disposition or a plan of care. So I would say the pictures are absolutely necessary. So when our office calls and hounds you that we need that information, or when we bother your referring cardiologist or referring provider, it's really because we want to see those pictures to be able to lay eyes on what the issue is.
Great, thank you.
Andrea, I'm sorry, may I interrupt just for a minute?
Of course.
I wanted to add about the echoes. My cardiologist actually showed me what my heart was doing and why I needed this procedure. I had 2 valves that were calcified and one was very sticky. So even though I had some blood flow out, I had some regurgitation as well. So that let me understand that I didn't have that rich oxygenated blood that I needed. That's why I was so tired. That's why I was having some of these symptoms. So to me, seeing that along with my cardiologist who was explaining that this is my heart and this is what's happening to me was very beneficial to me. So I encourage patients to definitely talk with their care team about the echo and what it shows.
Great. Thank you for that input. So somebody is asking, what do we know about the efficacy or dangers of reasonable strenuous exercise after TAVR? Are there long-term restrictions?
There are not long-term restrictions. I think one of the beauty of the TAVR procedure is that patients are able to get back to their baseline typically within a week. We do recommend cardiac rehab for all of our patients because sometimes you just don't realize how deconditioned you may have gotten from having this type of valvular heart disease. And, you have patients that kind of fall into 2 categories. Either they stay on the couch because they just had a heart valve replacement and there's a lot of fear around that, or they're like, ooh, I had my heart valve replaced, I'm going to go out and run a marathon. And so the great thing about, cardiac rehab is it kind of helps you navigate that activity level. But, as far as we know, we tell patients they can go bungee jumping, they can run marathons, and we have had patients who ran marathons after their TAVR procedure. So really no specific limitations. The things that obviously we're concerned about are the things that we're always concerned about, which is, tackle sports or things like this. But again, because you're not typically on blood thinners, it's not as much of an issue if you have a mechanical valve.
Great. The next question is, I had open heart surgery and received a bovine valve. It's been 7 years and it's moderately leaking now. I am 77. Not looking forward to another open heart surgery. What are the chances of me being a TAVR candidate?
Obviously I can't speak to a specific case, but I can tell you that valve-in-valve is approved for use in patients. And so a lot of our patients who come in who do have bioprosthetic valve failure are able to be candidates for a transcatheter heart valve after having an open heart surgery. And so I would say the odds are very good that that is an appropriate therapy for you, but of course, should be evaluated by a heart team.
Great. And then there are 2 questions. I think they're kind of related. One is about TAVR contributing to AFib, and what percentage of TAVR patients require a pacemaker immediately or 1 year out?
Okay, so we can go through some specific data on that, but I think with TAVR, it's actually more likely to have a pacemaker than with open heart surgery. And some of that is dependent on the actual valve type that's used, but can be anywhere from 5% to 18%, depending on valve type. For atrial fibrillation, the rate of developing atrial fibrillation after TAVR is actually relatively low as compared to surgical valve replacement. And so again, each of them has their pros and cons. And honestly, there are some things about patients' heart rhythms that may put them at an increased risk for having pacemaker, but that's something that would be discussed by your heart team when you're being evaluated for the TAVR procedure or open heart surgery.
Great. So what if there's a waiting list to get a TAVR? Should a patient look at open heart surgery to fix their valve instead if they can get that quicker, or should they wait?
I don't necessarily know that that's the right answer. I think, I don't know that I would choose open heart surgery just because I could have it done quicker. I think, again, going by that guidance that was put out by the American Heart Association, and just being quite honest about your symptoms with your healthcare team, to be able to negotiate dates. But, I can assure you, having worked with our TAVR program for the past 13 years, that if a patient calls me and tells me that they've got a concern, then it's my concern, and we'll do whatever we can to get them in as soon as possible, pandemic or not.
Great, thank you. So I think that we have come to the end of the questions that were in their queue. If anyone has questions and they'd like to have them answered before the end, please go ahead and feel free to type them in the question and answer box. But I would like to just give a few, a little bit of information about seeking care. This information has come from Heart Valve Voice, and they are a partnering patient organization. And they had some great guidelines as patients to look at when you're talking about, should I get care or not? Definitely seek emergency medical care if you're having a healthcare emergency. Make sure that you're maintaining clear lines of communication with your healthcare team. Do not delay treatment if your heart valve procedure has been deemed urgent or emergent. Make sure that you're your own advocate. And as always, stay in regular contact with your heart team if your procedure is not yet scheduled. And don't be surprised at changing protocols. Unfortunately, the world that we're living in now, we have to be very flexible in changing protocols, because we are all of us, learning as we go and changing things as we find new answers. And so what is an answer today may not be the answer tomorrow. And I think that it's really important for us to all realize that when protocols are changed. Some other helpful resources for you all. Of course, mendedhearts.org. We have lots of information and education. You can find all of our past webinars on our YouTube channel. And so you can look up anything that you're looking for at our mendedhearts.org website. Heart Valve Voice US, the Alliance for Aging Research, is another nonprofit. Cardiosmart.org is the American College of Cardiology's website that has a lot of patient education materials. There is the newheartvalve.com, which is industry sponsored, but it's educational, and it's a website that is designed for aortic valve disease and TAVR, and it's great. A couple of things. Tomorrow is Go Red Day. So it's National Wear Red Day. So everybody should wear red and snap a picture. If you take a picture and you come to our Facebook page on Monday night, when I'm hosting our Facebook chat, you will have a chance to win some shirts that we're giving away. It's going to be fun. And then Heart Valve Disease Awareness Day is February 22nd. So mark your calendars. And make sure that you spread awareness of heart valve disease. Again, we are at mendedhearts.org. You can feel free to join us. We'd love to have you. And one final note about becoming a virtual visitor volunteer. We have done the great pivot, and we are now providing peer-to-peer support and education virtually. We have a heart hotline, which we call the Heartline, where people can call and get a peer support visit from 10 to 6 Eastern time, Monday through Saturday. It's a national and chapter group virtual visiting program. And this is a way that we can get our services to more patients and families than ever before. And we can reach patients and families in the hospital or out of the hospital, regardless of where you're at. So you can visit us at myheartvisit.org. And that is there. And I think we've got another question that has popped up in the meantime.
Several, Andrea, back into the Q&A.
Perfect. Thank you. So what is the average length of a hospital stay? How common is same-day discharge?
So quite honestly, same day discharge was, really, it had been done very, very rarely prior to pandemic, and we're seeing it popped up, all over the United States now. I would say it is not the traditional route, but the average length of stay is 1.6 days. So just, it would be a next day discharge after TAVR. But there are a number of organizations that are doing same day discharge right now.
Great. And with the same topic, someone says, I heard you don't need to go to the ICU after TAVR. Is that the case?
And that is very dependent on the organization. For our organization, we have not sent patients to the ICU unless if there was a medical reason they needed to go to the ICU. So to be clear, but the standard process is for patients to recover on a telemetry ward so that we can monitor your heart rhythm. But we have not sent patients to the ICU in about 9 years. And a lot of organizations have gone that way as well.
Great. So have there been many cases where a TAVR valve failed after a few years?
Many cases, no. Can it happen? Absolutely, yes. And it can happen with a surgical valve as well. But the great thing is you can do, TAVR valve in valve, or you can do a TAVR valve in a surgical valve as well. So there are a number of options for treatment. We estimate that, transcatheter valves, again, as we continue to learn, because in the scope of healthcare, TAVR, I don't want to say it's relatively new, but the first one was done in 2002 in Rouen, France, and really started in trials here in the United States in 2006 and 2007. So we continue to learn, but we tell patients, likely 10 plus years.
Great. Kathy, I got a question for you. Someone wants to know one piece of advice that you would give patients considering these options of open heart surgery or a less invasive procedure.
Again, I must stress the importance of discussing with your healthcare team from the very minute first questions you have to the more extensive after you discuss surgery. You can do your own research, but then you draw your own conclusions. Bring that information with you to your healthcare team to discuss in depth to get the answers that you truly are seeking. And you can make the best decision that way and getting all the necessary information. So again, it's just reaching out, making that contact.
Great. So I have a question here. It says, how many TAVR patients develop heart failure?
Well, prior to the procedure, technically all patients have heart failure because of the valvular heart disease. It's whether or not you have symptoms or not, but your heart's not working the way that it should because it has an obstruction. That aortic valve doesn't open and allow that blood to go out to the rest of the body. And so it does, it just doesn't, it's not an efficient pump. And a lot of times we describe it as if you have your finger over a hose and you're spraying, it sprays very inefficiently fast in some areas and not in other areas. And that's kind of what happens. And so when we remove that obstruction, we get a much more functional pump. And in, most patients, after their TAVR procedure, their heart failure is resolved. It's it's not an issue any longer, but it's certainly something after any heart valve procedure, whether it's surgical or a transcatheter procedure, you need to be managed and your valve needs to be periodically examined. And that's why we ask you to stay in care, even if you've already had a procedure.
Absolutely. Great advice. This question is, how much of a difference is there in valve repair? And I'm assuming they are meaning open heart surgery, valve repair, and TAVR. And how does one find centers that do this?
Okay, well, there's a two parts to that question. So number one, a stenotic valve, no matter which valve it is, if it's mitral or aortic, you can't repair a stenotic valve because it's calcified and you really can't sew through calcium. And so that's just not an option, unfortunately. For regurgitation, depending on the type of regurgitation, and again, everybody is a little bit different, repair is usually preferred to replacement in the mitral valve. And so again, we're kind of talking about which valve that is and what that looks like. So in those cases, it's really best to work with your teams to figure out, what that right solution is. As far as, repair replacement, it is the difference between a transcatheter procedure with a shortened recovery and back to baseline versus an open heart procedure where there, may be necessary to have to be on pump or to, go on the bypass machine, sternotomy. There are some other options, whether it's robotic surgery or things like this. I think that can be very helpful. There are a number of ways that you can find your valve center. And for patients, one recommendation that I'll make, and I don't mean to be avant-garde or anything like this, but I do think doing a search to find, valve programs in your area or word of mouth, or even reliance on some of the websites. I know you had shown New Heart Valve before, but you can put in your zip code and it will pop up with, what valve programs are in 25 miles of your area. And just remember, when you go into a valve program, we're not just looking at you for one specific therapy. There may be things about you that you don't even know that it's my job and the team's job to know and find out about you and make those recommendations what that best therapy is. But I think, to Kathy's point before, we make recommendations, but it's your body and it's your health, and we want to honor what we can. And so having those conversations and making sure that there's a shared decision-making process is really vital to the success.
Great, thank you. Kathy, someone has it's a comment and a question for you. One is that they're already feeling isolated enough. The thought of going it alone in the hospital is not something that they feel ready for. What do you recommend to help me through this and how my family can feel more comfortable with it?
There are several things I think that one can do. And the first is to involve your family in your decisions and what your wants and wishes are, and explain your feelings to them and how they can stay in touch with you while you are isolated in the hospital. I think my choice was I did not bring my cell phone or any other device with me in the hospital. Again, just because of COVID, I didn't want to take any necessary chances. But my husband did call me frequently. And as I said before, the staff is so willing to take time to be with you. I didn't really ever feel like I was alone per se. And I think it also depends on your mindset. I viewed this as a very positive experience, and I was doing this for my health and for my well-being. So whatever I had to do, I was going to suck it up and do what I had to do, in other words. So was there another part, Andrea, question that I mean?
No, I think that was it. They were just, wondering some advice on, how to get yourself through it by being alone. And I loved how you said you never really felt alone because the hospital staff was there so well taking care of you.
Yes.
That's so important to know.
They did.
You won't be alone. You just will have different people, they are.
Right.
Somebody else wants to know if you have questions to ask your doctor, Kathy. What questions would you suggest that a patient ask their doctor about this procedure?
Oh my goodness. I had a list when I went in, and I think if you do your own research, and if you do talk with other patients, you already have a sense of what's kind of to be expected, and to devise your own questions and concerns, write them down, because I tend to forget myself. Once I get to a physician's office, we start talking about other things and I totally forget what I want to say. I think it is individual to each person. I can't say specifically, what to ask, but the things that I was concerned about was time frame, after TAVR, excuse me, what can I expect as far as recovery? And of course, this is after all of the surgery had been explained to me. So I was more concerned on the other side of the coin, as to what to expect after the procedure. I think whatever is on your heart and mind that concerns you the most is what you should talk with your provider about first, and everything else will come to you, and make a list and ask those questions as well.
That's great.
Yeah.
And I think it's really important to make sure that, if you are scared or you are fearful over something, that you are very honest and open with your
Yes,
provider.
absolutely. Absolutely. Yes. And even to the staff at the hospital, because when I was in the surgical suite, it was, I'm really nervous about this. I was honest with them. And that called their attention. I know they were busy preparing, but it called their attention back to the patient that was lying there. So I didn't mind telling them that I was nervous and what is happening next. So it does help to speak up. Be your own best advocate. That's my motto.
And I just want to add on here, obviously I think that's really sage advice from somebody who's been through this, but, Andrea, you went through a number of resources before, and on a lot of those websites, especially CardioSmart, there are guides for talking to your providers, because again, it's hard to know what you don't know. And so a lot of those have lists of questions. And I know also on New Heart Valve, they have that as well, that you could bring it into your provider and ask those questions as well, just give you ideas of what to be prepared for.
Great. Thank you, Tricia.
Yeah, that's great. And I think we have time for one more question before we finish up the hour. I can't believe it's already been an hour. Someone has asked, how long do you think it will be before the mitral valve can be replaced via a catheter?
Honestly, we have trials right now that are doing it. And before we talked about repair, there are approved device for repair and other ones that are in trial. And we are in the process of doing studies on transcatheter mitral valve replacement. And there is one device that is approved in Europe that the trials are ongoing here in the United States. So, stay tuned for that. It's super exciting to be able to be a part of that.
So exciting. So exciting. Thank you. So I'm sorry, one last question to Kathy. Somebody wants to know if going to the dentist is scarier than a TAVR now.
That's ironic because I just went to the dentist, and in a way it is, because I didn't quite feel as protected in a way. But yes, I mean, they were taking precautions too, but it's a totally different experience. And I would have to say, in a way, yes, it actually was for me. It was a little more fearful going to the dentist, but I survived it.
Yes, I just took my kids to the dentist, and I have to admit it was a little scary. I mean, we did it, but I was like, I feel like I shouldn't be here. Like, we have to take the mask off, and
Exactly.
Right. So, well, thank you all. I just want to end by thanking you both, Patricia and Kathy, for such amazing information and for sharing all of this great resources and education to our patients and families out there. Thank you all for joining us. We're so excited that you were able to spend an hour with us. And thank you to our sponsors who have made all of this amazing education possible through our Stay in Care series. So thank you all, and we look forward to seeing you back the next time. Have a great day.